much seen in West. It is seen in post-neonatal period. So it is different from PPHN, which is seen in neonatal period. In the post-neonatal period, it is triggered by a respiratory tract infection, group pertussis or anything. It's basically, it has been observed that most of the times there has been a trigger of RTI, following which the child ends up in pulmonary hypertension, right heart failure symptoms. These infants usually are well-nourished, breastfed infants. These infants look well and have always been well before they land up in pulmonary hypertension. There is a history of exclusive breastfeeding, and the mother has been consuming polished white rice based diet, and the mother is basically having a subclinical thiamine deficiency. The child, being very metabolically active in this particular age, presents clinically with overt thiamine deficiency. Why does this happen? There are two mechanisms by which pulmonary hypertension develops. As we know, thiamine deficiency, it causes a state of acquired mitochondriopathy. So we have a failure of Krebs cycle and ETC leading to less and less ATP production. Because there will be less and less ATP production, there will be more and more adenosine, which will lead to systemic vasodilation, systemic hypotension, and ultimately will lead to a high output left-sided heart failure. This leads to increased LVEDP. And this increased LVEDP further causes pulmonary venous hypertension, which ultimately leads on to pulmonary arterial hypertension and right heart failure. Then, because there is an energy failure, there will be a lot of lactic acidosis. And this lactic acidosis itself is a potent pulmonary arteriolar constrictor leading to pulmonary arterial hypertension. And again, because there is an energy failure primarily, there will be myocardial depression and dysfunction. And it has been seen that this myocardial dysfunction in an infantile age is more severely affecting right heart compared to left heart. And therefore, we have a picture of pulmonary arterial hypertension. The second mechanism is reactive oxygen species or free radical formation. Whenever there is a thiamine deficiency state, there's a lot of free radical formation which converts nitric oxide into peroxynitrite. Now we know nitric oxide is a vasodilator, but peroxynitrite, it is a potent vasoconstrictor, and this leads to pulmonary vasoconstriction leading to pulmonary arterial hypertension, ultimately leading to right heart failure. In many of these cases, there is a history of previous sibling having similar clinical picture around the same age, which either points that there is a genetic predisposition to develop pulmonary hypertension, or the mother has been having a persistent state of thiamine deficiency since ever. If you look at this particular case, in this chest x-ray of a 2.5-month-old kid who clinically presented with respiratory distress and peripheral edema following an episode of respiratory tract infection, we can see bilateral haziness in the lung fields, and CTR is approximately 60%. Upon doing an echocardiographic evaluation, we can see that RARV is dilated, and there is flattening of interventricular septum suggesting increased right-sided pressures. And on doing a Doppler imaging, we can see there's a tricuspid regurgitation jet. This kid was started on pulmonary vasodilators, but did not substantially respond to the vasodilators until thiamine was infused at a dose of 100 mg over 1 hour. The child responded drastically to this. This is one way of objectively diagnosing thiamine deficiency and thiamine responsive pulmonary arterial hypertension. Otherwise, the standard laboratory assay basically measures something called as RBC transketolase activity. Now, we all know that in RBC, glucose, most of the glucose undergoes glycolytic pathway. But 5 to 10% of glucose via glucose 6-phosphate is acted upon by G6PD, and it enters the HMP shunt, wherein it is acted upon by the enzyme transketolase. This transketolase requires thiamine as a cofactor. If there is a thiamine deficiency, we'll see the RBC transketolase activity will be very low. And if we measure this transketolase activity after supplementing thiamine pyrophosphate, and in comparison to the activity level without giving TPP, if the activity increases by 15%, it is called a significant increase. And signifies that there was a deficiency to begin with. This is called increased thiamine pyrophosphate effect. If the increase is up to 30%, it signifies a severe thiamine deficiency to begin with. Now, how to treat this deficiency state? Whenever we have a neuritic form, a cardiac form, or a mixed picture, we need to start with parenteral dose, which is 10 mg per day for 1 week, followed by per oral dose 3 to 5 mg per day. It is 3 to 5 mg per day for 6 weeks. And the cardiac response is drastic and dramatic, whereas if it was a nerve disease to begin with, the response is often slow and incomplete, especially when we are talking about infantile age. And the survivors of severe infantile thiamine deficiency, they usually have a residual neuritic form or residual debilitation after getting cured of the acute episode. Lastly, if you're talking about thiamine responsive megaloblastic anemia or other dependency states like biotin and thiamine responsive basal ganglia disease, they basically require higher doses to the order of 100 to 200 mg per day, and the treatment is lifelong. So that's all about thiamine. I hope these concepts will be very helpful for you in your practice, and you can keep revising them from the lecture. Thank you.